Thank you, everyone, for joining us this evening as Dr. Pamela Smith presents the complex patient, What to Do on Monday Morning. This workshop will be presented live in Las Vegas on May 4th through the 6th at the beautiful Wynn Hotel. I would like to introduce our speaker this evening. Dr. Pamela Smith spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center, and then the next 20 years as an anti-aging functional medicine specialist. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic, anti-aging, and functional medicine. She also holds a master's in public health degree, along with a master's degree in metabolic and nutritional medicine. She has been featured on CNN, PBS, and many other television networks, has been interviewed in numerous consumer magazines, and has hosted 2 of her own radio shows. She is a regular contributor for Fox News Radio. Dr. Smith is currently the director of the Center for Personalized Medicine and the founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine. Dr. Smith is also the co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morsani College of Medicine, University of South Florida. She is the author of best-selling books, HRT The Answers, Vitamins, Hype or Hope, Demystifying Weight Loss, What You Must Know About Vitamins, Minerals, Herbs, and More, What You Must Know About Women's Hormones, Why You Can't Lose Weight, and What You Must Know About Memory Loss and How to Stop It, What You Must Know About Thyroid Disorders, and What You Must Know About Allergy Relief, of which she is the co-author. Her newest book, What You Must Know About Autoimmune Diseases, is scheduled to come out this summer. If there are questions throughout the webinar, Dr. Smith will take a break and we'll answer those questions. You can submit your question using the chat option and I will read those. Dr. Smith, we're very excited. I'm going to turn the webinar over to you.
Thank you so much, Lindsay. Tonight we're going to look at the idea of the complex patient. I mean, really, what do you do on Monday morning when someone comes in with a myriad of complaints? So this is going to be a 47-year-old perimenopausal female who has come in to see you with the chief complaint of fatigue. Past history significant for surgery to her right foot. Her LMP was 2 weeks ago. She's a teacher. She's been having a hard time going to work due to her fatigue. She's not been exercising because she's tired. Family history is positive for an aunt with rheumatoid arthritis. She's taking metformin for her insulin resistance. Nutrient, she's on a multivitamin, and she's also complaining of anxiety, irritability, mood swings, and depression. Her physical examination was non-contributory for what we're going to look at tonight. So what do you do? This person has fatigue. Well, there's a lot of reasons for fatigue. Patient could be anemic. Patient could have many kinds of infection, from Epstein-Barr to cytomegalovirus, to mold, to Lyme, to yeast, to parasites. They could have adrenal dysfunction. Perhaps they lack fuel or have the wrong fuel so that the mitochondria are not being fueled. She's on a medicine. She's on metformin. Metformin causes nutritional depletions. Maybe she's hypo or hyperthyroid. Either way, being high or low with thyroid can cause fatigue. She doesn't sleep, she can have fatigue. Allergies can cause fatigue. She could aggressively exercise, and that could cause fatigue. That's not the case here, though, because she hasn't been able to exercise due to fatigue, but certainly everything else on this page we have to look at. So what test do you really want to order on this patient? Well, certainly you want to look at the fact that she's perimenopausal, so you would get a saliva test, and I usually do a 6-day saliva test in perimenopausal women, starting with day 16 of their cycle so you can catch ovulation. On that same test is going to be melatonin to see if there's any issues with the insomnia being low melatonin. On that same test is also going to be cortisol, along with her female hormones. So we'll really get a wide breadth of information from that test. Blood work-wise, of course, we want to look at blood sugar because she's had a blood sugar problem. We want to look at thyroid. We want to look at pregnenolone and really just get a basic profile of kidney and liver function and, of course, complete blood count to make sure she's not anemic. We do want to do a gut health test to make sure she doesn't have yeast or parasites. She could have mold, Lyme, allergy testing, micronutrient testing to see if she has nutritional depletions, and organic acid testing would be another really good idea here to really see what's going on with the mitochondria and see if there's oxidative stress. Now, there's several ways you can approach this. You can order one of these tests and keep on plodding along, or what I more commonly nowadays do, but I didn't do before, is I may order all of these, knowing that they're probably all abnormal. And I tell the patient that, even if I order half of these, that I'm going to order these tests, but I can't fix everything at one time. And I make sure the patient hears me. I say it 2 or 3 times. You also have to stay in business as a practitioner. So there's 2 reasons you don't want to fix everything at one time. 1, the patient gets confused and the body gets confused and fixes nothing. 2 is you do have to spread out the visits so that the patient pays you enough for doing all these tests and reading the test. There's nothing wrong with saying you need to stay in business. You help no one if you don't pay the light bill. So clinical pearls, again, you cannot fix everything at one time. So fix one problem, wait a month, then fix the next issue. Always treat infection first if it's present, which is why I more commonly now end up ordering these tests as a battery and then come back and fixing them. If the gut does not work, the patient cannot absorb her therapies. So you can give her all the hormones in the world, you can give her all the nutrients, all the antibiotics. Gut has to work for her to be healthy. So these are just some clinical pearls here. So any questions before we go on to what her test results showed?
Thank you, Dr. Smith. At this time, I do not see any questions, but again, if you do have questions, just use your chat option. Thanks, Dr. Smith.
Perfect. So she was positive for Lyme. She did have toxic mold. She was hypothyroid. Her reverse T3 was elevated, which meant that her mitochondria were not feeling well, and her thyroid antibodies were positive. We did do a GI effects test to look at her stool for gut health. It was not normal. Her saliva test revealed hypoadrenalism, or low cortisol, low DHEA, low progesterone. Her allergy testing revealed that she was severely deficient in almonds, and that should say dairy. Also, she was gluten intolerant. Micronutrient tests revealed that she was deficient in B vitamins, CoQ10, and organic acid testing revealed numerous deficiencies. It showed that she needed probiotics. On her organic acid test, it also showed that she did not have good ability for phase 1, phase 2 detoxification, along with nutritional deficiencies. So goodness gracious, where do we start with this patient on Monday morning? Well, again, treat infection first. So you want to go ahead and treat her Lyme and mold. She did have an infection in her gut, but Lyme and mold come first. So we started her on triple therapy for her Lyme and mold. Important to do when you look at Lyme testing, it's important that you treat everything, because with Lyme there's cell wall forms, cystic forms, and intracellular forms. So I lovingly call the spirochete that causes Lyme a Klingon. If you're a Star Trek fan, you know what I mean. It hides, it cloaks itself. So you do need to give an antibiotic for cell wall forms, something like a penicillin or a cephalosporin. You need to do something about the cystic forms, something like grapeseed extract or Plaquenil, and then intracellularly, something like Zithromax. There's many, or a tetracycline. There's many ways to look at it, but you really have to treat all of the above. So we started her on a Lyme protocol, and if you just took Module 6 in Charleston, You had the advantage of hearing two great speakers on Lyme. One of those was Dr. Richard Horowitz, internationally known expert on Lyme disease, and Dr. Andy Heyman, also an internationally known expert on Lyme. Both gave absolutely fabulous talks. So if you have not taken Module 6, then avail yourself of that, because Lyme is something we have to look at. Also with probiotics. The patient is going to be on an antibiotic. You want to make sure they start on probiotics, but they take it at a different time than the antibiotics. And the antibiotics for Lyme are usually given every other day. So one day you take one antibiotic, the opposite day the other antibiotic. Mold test was positive, and it was positive for gliotoxin. There's 4 different molds that are checked on that test. And that test is very important to do. It's a urine test. Okay, Lyme is a serum test. And mold test is real-time labs. The Lyme test was IGeneX. And with the mold test, with the positive gliotoxin, the treatment for that is liposomal glutathione. So we started the patient on liposomal glutathione. So that was the thing we did first. Then we brought the patient back. Okay, in a month, we did start the probiotics because the patient was going to be on antibiotics. And at the next visit, we dealt with what was going on in the stool. The good news is that tetracycline we gave for Lyme was also going to treat that Pseudomonas that she had in the stool. Her stool test showed that she was deficient in good bacteria. So the good news is the patient's already on probiotics, but there was also a decrease in short-chain fatty acids. There was fecal high cholesterol, so the patient also needed a digestive enzyme. They were also positive for beta-glucuronidase, so we started the patient on milk thistle, 200 milligrams BID. So we're getting the gut healthy, so it can absorb all of this. We bring the patient back again. At that point in time, we decided to look at hormones, because remember, she had anxiety, irritability, insomnia. On the GI effects test also, which I didn't mention, is she was positive for yeast. Yeast can cause anxiety, irritability, insomnia, mood swings. So at that time, we started her on diflucan. She was sensitive to it, 100 milligrams BID for 2 months. So now we have hormones. Saliva test, she was low in progesterone, so we treated accordingly, days 14 through 25, because she's still perimenopausal. She was low in DHEA. We remember start low, go slow. So we started her on DHEA at 5 milligrams in the morning, E4M, which is sustained release. She did have low cortisol, so we gave her a good multivitamin, better than the one she was on, which was not pharmaceutical grade. We had her do stress reduction techniques, adaptogenic herbs. We also gave her calming herbs. At that time, we also looked at her blood work. Her fasting blood sugar actually was better than I thought it was going to be. It was 87, hemoglobin A1C was 5.4, and her fasting insulin was 8. So her metformin was doing pretty well for that. So we didn't have to do anything with the blood sugar. The rest of her blood work looked normal, except for the thyroid. We're not going to do anything with the thyroid right now from the viewpoint of giving medicine, because what we're going to first of all do is an iodine test to see if she's hypothyroid from the fact that she's low in iodine. She does have an elevated reverse T3, which means she has a problem with thyroid transport of that hormone into the cell. And that usually is a mitochondrial issue. She did have elevated thyroid antibodies. So we did take her off of gluten, and we fixed her gut in the previous visit, so that was helpful as well. Her test came back on iodine testing, that her iodine was normal, so we brought her back in 6 weeks to start her on thyroid medicine. Now remember, you always want to fix the adrenals, start those adrenal adaptogenic herbs for at least 6 weeks before you start the patient on thyroid medicine. And when we brought her back, remember she's got positive antibodies, so we're not going to start her on porcine thyroid. We gave her a non-porcine compounded thyroid. So that's what we did in that visit, and that was a short office visit, so I actually charged her less money because that was just a single issue. The next month, we brought her back, and we went over allergy testing results. We just took her off of dairy and almonds. She was already off of gluten. And then we also did the micronutrient testing and organic acid testing. There's no surprise with the micronutrient testing, that's a SpectraCell test. The allergy test was Genova. The saliva test was a Genova test. And what we did with the micronutrient test is it had B vitamin deficiencies and deficiency of Q10. No surprise because she was on metformin. Metformin depletes the body of Q10 and B vitamins. Plus, we know from her elevated reverse T3 that she does have a mitochondrial problem. Her organic acid testing actually showed everything that we just showed. Everything we discussed. It showed there was a mitochondrial problem. It showed that she needed probiotics, etc. So we put her on the following nutrients beside taking her off of the things she didn't need for her allergies. We put her on coenzyme Q10, 200 milligrams a day. We put her on D-ribose, 15 grams. We gave her magnesium, 400 milligrams of magnesium glycinate. We gave her carnitine at 1,000 milligrams. At some point in the near future, I'm going to want to measure TMAO to make sure that it's okay for her to be on carnitine. So you always want to do that before someone stays on carnitine very long. We started her on alpha lipoic acid, 300 milligrams. That's going to help her blood sugar. It's going to help prevent neuropathy. It's going to be great for memory. It's also going to refuel the mitochondria. So an important aspect. And lastly, NADH, 10 milligrams BID. Those are all the nutrients that help refuel the mitochondria. I'm sure you all remember from module 1 in the thyroid talk on how to deal with elevated reverse T3. So again, Q10, 200 milligrams, D-ribose, 15 grams, magnesium glycinate, 400 milligrams, L-carnitine, 1,000, lipoic acid, 300, NADH, 10 milligrams BID. And that really did end up covering everything that was on the remainder of the test. And remember, we're going to remeasure her thyroid studies in 6 weeks. We're going to remeasure her hormones in 90 days. Questions so far?
Thank you, Dr. Smith. I do have some questions coming in. Can you comment on the GI map test, and would you use it in this patient case?
There's many ways of looking at GI. Certainly you could look at maps, absolutely. So that would be a very legitimate way of doing this as well.
Thank you. Dr. Smith, is there a one go-to for all tests to minimize patient blood test time and confusion, etc.?
No, I wish there were. But what we're trying to do here is look at the cause of the problem, not just treat symptoms. And what we're trying to do is provide individualized and customized care.
Thank you. Dr. Smith, can you comment on the Lyme and the mold test that you used in this patient case?
What was the question on the Lyme and the mold? You mean what company?
Yeah, it looks as though they're looking for the company name on the Lyme and the mold testing.
The company name on the Lyme was IGenX, IGENX. and the mold test was real-time labs.
Thank you. Dr. Smith, why wait 90 days to retest female hormones?
We always wait 90 days because it takes 90 days for the hormones to go back and rebalance themselves amongst each other. To be specific, it takes about 30 days for progesterone. For testosterone and DHEA, it takes about 60 days. But for estrogen, it does take 90 days. So it's rare we change the dosage before 90 days has gone by.
Dr. Smith, can you elaborate on the relationship of TMAO and carnitine?
That's a whole seminar in itself. So if you have elevated TMAO, then what you don't want to do is give a patient carnitine. It increases their risk of heart disease. That's discussed in Module 5. Module 5 is really how to interpret functional medicine labs. So that's gone over extensively in a whole seminar on TMAO. That's also mentioned. That's also discussed in Module 2 with Mark Houston.
Thank you. Dr. Smith, what are the consequences of a patient seeing an endocrinologist who treats the thyroid versus adrenals first?
Well, the consequences are not so much when someone's younger, but as they age, then what can happen is if you don't treat the adrenals first, you give the patient thyroid, it revs up the system. When it revs up the system, the body may not be able to take it on because the adrenals aren't functioning as well. The patient may get heart racing, they may get a headache. In other words, symptoms of hyperthyroidism, even if they're not hyperthyroid.
Thank you. Dr. Smith, can you explain the mechanism of D-ribose on mitochondria?
That's beyond the scope of what we're talking about tonight, but that is discussed in Module 1.
Thank you. Dr. Smith, what supplements are most helpful for adrenal fatigue?
Well, the most commonly used nutrients are ashwagandha, ginseng, and rhodiola. And almost every nutraceutical company makes a variation of that. With Metagenics, it's called Adracet. With Orthomolecular, it's Adrenovive. With Zymogen, it's Adrenal Essence. I could go through every company. I don't think there's really a nutraceutical company that doesn't make adaptogenic herbs.
Thank you. This time I don't see any more questions coming through, but if you do have them, please submit them now.
This patient started to feel better over time with each new therapy. She was about 60% better, but had much more improvement when we started on low-dose naltrexone. Now remember, the patient has an autoimmune disease. And Module 7 discusses autoimmune, but when we look at autoimmune disease, we always do take the patient off of gluten, fix the gut, and start LDN. So LDN is FDA approved for alcohol dependence. It's for the prevention of opioid-dependent relapse and obviously overdose in larger doses. And there's 4 major subtypes. And there's receptors and ligands. And there's an immunomodulating effect on morphine that's been characterized in human and animal trials. Naltrexone is a competitive antagonist on opioid receptors, mu, kappa, and delta. And naltrexone can either displace opioid agonists from binding at these receptors or prevent opioid binding. By turning the key in the opposite direction, the immunomodulatory effects of naltrexone can be used to help patients in a unique way. So that's displayed in this graph here. So there is a difference in what you're trying to do with high dose or regular naltrexone versus low. Counterindications to naltrexone: acute hepatitis, liver failure, and recurrent or current opioid alcohol ingestion. Again, we're not trying to treat that when we're looking at low-dose naltrexone. We're looking at a totally different story. So what are the uses? We can use it for Crohn's disease, multiple sclerosis, fibromyalgia, chronic regional pain syndrome, cancer, Lyme disease, ALS, AIDS, itching, eczema, psoriasis, irritable bowel, dry eyes, weight loss, Hashimoto's thyroiditis, Graves' disease, rheumatoid arthritis, Parkinson's disease. I've used them in all these and more. So every one of my patients in my personal practice who has an autoimmune disease like this patient is on low-dose naltrexone. So the dose of low dose is usually 3 to 4.5 milligrams. Anything beyond 6 milligrams is no longer low dose. LDN is hypothesized to increase the production of endogenous opioids during short-term blockade of opioid receptors. It's very anti-inflammatory, and it has a very wonderful positive effect on the immune system, and it affects immune modulation. So here's the different mechanisms why or how the immune system is affected with low-dose naltrexone. So in the higher doses, it's an opioid receptor antagonist. It inhibits T and B cell function and NK function, IFN, and interleukin-2 production. Low dose, it's an opioid receptor agonist, so it stimulates T and B cells, natural killer cell function, IFN, Y, and interleukin-2 production. So low-dose naltrexone increases in endogenous enkephalin and endorphins, which enhances immune function. It inhibits pro-inflammatory cytokines, so it improves inflammatory reaction. It has a positive interaction of the nuclear opioid growth factor receptor, promotes DNA synthesis, so it heals corneal ulcers. It's been shown to have a blockade of opioid R in the GI tract, so it heals and repairs the mucosal tissue. It has a positive effect on liquid stools, so it can improve Crohn's and ulcerative colitis. It also has an effect on the regulation of Treg and the production of interleukin-10 and TGF-beta. So in other words, it downregulates Th17. Any side effects? Certainly the most common ones, insomnia. Otherwise, the patient can have vivid dreams, fatigue, loss of appetite, nausea, hair thinning, mood swings, or mild disorientation. In all honesty, I have hundreds of patients on low-dose naltrexone. The only one I've personally seen out of these is insomnia. Potential long-term side effects, possible liver and kidney toxicity. Haven't seen that. We're supposed to tell you that. Possible tolerance to the beneficial rebound effect. Haven't seen that. And any unknown sequelae that we haven't looked at. So if you look at Crohn's, here's a study. LDN was both safe and effective in the treatment of Crohn's disease. Patients were allowed to continue their other medicines. 89% of patients exhibited a response to therapy. 67% of people achieved a remission. So here's another Crohn's disease follow-up study. A prospective double-blind randomized placebo-controlled trial of patients with Crohn's and the use of LDN. Patients did very, very well. After 12 weeks, 78% of the subjects treated with naltrexone had an endoscopic response that was positive. Animal trial, again, very good results. The patient was treated, the laboratory animals were treated with sulfasalazine, LDN, as a combination, and they had the laboratory animals, which were rats, significant improvement. In MS, I have a large MS practice. My practice is in Michigan. As you all know, MS is much more common in the northern tier states and provinces. Low-dose naltrexone, very good for MS. It reduces apoptosis of the oligodendrocytes, reduces inducible nitric oxide synthase, and it decreases the formation of peroxynitrites. So it helps prevent the inhibition of glutamate transporters. Pilot study here, single center double masked placebo-controlled trial, 4.5 milligrams QHS of LDN, self-reporting better quality of life from the Annals of Neurology, and another study from MS Journal. Fibromyalgia, which is really an autoimmune disease. Great study in anti-inflammatory effects. Look here at the patient global impression of change after LDN. 37% of people were much improved, and you can see the rest on this pie graph. Study looked at LDN at 4.5 milligrams QHS for fibromyalgia, randomized small trial, double-blind, placebo-controlled, counterbalanced crossover trial, which assessed daily pain levels. The preliminary evidence showed that low-dose naltrexone had a beneficial effect on fibromyalgia pain, and it was safe and little side effects. So again, this is because of its great anti-inflammatory effect. 8 women in this other trial, which came out last year, LDN was associated with a reduction in the interleukin inflammatory factors, TNF-alpha as well. 15% reduction of fibromyalgia-associated pain and an 18% reduction in overall symptoms. In this study, the efficacy of LDN for fibromyalgia was not effectively treated with conventional therapy. So they actually, in the study last year, people that didn't have success with traditional medicine had some with LDN. Chronic pain. Low-dose naltrexone for the treatment of complex regional pain syndrome. Better activity on the opioid receptors. Even cancer. Here's a study looking at LDN and ovarian cancer in animals, where mice were established ovarian tumors treated with LDN. There was a short period of opioid receptor blockade, repressed tumor progression, and the little laboratory animals did better. They also had less weight loss. With pancreatic cancer, 3 case histories. This is a human trial. IV alpha-lipoic acid and oral LDN. The authors of these case studies suggest we actually do a clinical trial. Lyme disease. Anecdotal reports are a myriad of them. I can tell you in all my patients with Lyme, I do use LDN. I use it as a second therapy. I start them on the antibiotics the first month, and then the next month I put them on the stevia protocol, because stevia has been shown to kill Lyme, and I put them on low-dose naltrexone. ALS has been beneficial. Patients with ALS, short-term blockade, which causes an increase in endogenous opioid release. There's an anti-nociceptive and anti-inflammatory action. And in LDS patients, the fatigue, pain, spasticity, and depression did better. HIV, studies have shown that LDN is both safe and effective. How about itching, like systemic sclerosis? This pruritus can be quite severe. 3 case reports of patients that had significant improvement in pruritus and total GI symptoms with LDN. How about LDN and itching in the elderly? Because naltrexone is a pure opioid antagonist, it blocks the effects of opioids. It can be very effective in people who have severe intractable pruritus in older patients. In this study, in a burn unit, significant decrease in itching in burn patients 2 weeks after low-dose naltrexone. This itching and scratching was decreased 44.5% of the patients. You can use LDN topically. It can be compounded topically or orally, and it works very well topically for itching, and you would use LDN as a 1% cream. And I usually put that in Versabase. I usually put that one in Zematop. Starts with an X, Zematop. And the reason I put it in Zematop is that particular base is for people that have an inflammatory process going on. So that's 1% naltrexone in Zematop. How about eczema and psoriasis? Again, it's autoimmune diseases. Take the patient off of gluten, fix the gut with the 4R program, and 1% topical naltrexone. Very, very good. You can even use it with other immunomodulatory drugs. IBS. In this study, patients with IBS without evidence for small bowel bacterial overgrowth were given LDN. Patients improved. Crohn's disease. These studies show that LDN improved active Crohn's disease, weight loss. Been using it with weight loss for quite some time. One of the side effects of LDN is decreased appetite, and it does work for weight loss because it decreases the appetite along with improving insulin resistance, which would be helpful to this patient, increasing growth hormone, decreasing inflammation, and decreasing sugar cravings. Dry eyes. In an animal trial, eye drops of naltrexone were found to be helpful for dry eyes. So how do you give naltrexone? Most common way is the following, and again, it is compounded. 1.5 milligram capsule QHS for 7 days. The next week you double that, so they're taking 2 1.5 milligram capsules or 3 milligrams. Then the third week, you're going to add a third capsule, so they're on 4.5 milligrams. And then if that dose works for them, you just have a compounded after that for 4.5 milligrams. I have a couple people that had severe insomnia at 4.5, and I had one, now that I think about it, that had nausea, and they went down to 3 milligrams. I have 2 patients on 6 for weight loss, but the rest of my patients are on 4.5. Usually the insomnia goes away within 4 days. If it is still there, you can back up the time that the patient takes the naltrexone and give it at 6 p.m. So LDN, really great for autoimmune diseases. In this case, the patient, we used it for Lyme and we used it for her Hashimoto's thyroiditis. So kind of a bird's eye view there, looking at the complicated patient. And this is my patient, and here, I mean, this was a year's process in what we just talked about tonight. Questions?
Thank you, Dr. Smith. I do have some questions coming in. Have you found LDN helpful for Parkinson's?
I have very much so. I love LDN for Parkinson's disease, absolutely, positively, without a doubt. Every one of my Parkinson's patients is on LDN. So far, I've been getting good improvement with all of them. They're all also on glutathione and the other things we talk about in Module 3 for Parkinson's disease.
Thank you. How do you manage patients who react to LDN with insomnia, even if taken during the day? Does this tend to go away?
It does usually go away in 4 days. Some of those people you may have to put down to 3 milligrams, but yes, and usually within 4 days it does resolve.
Can you comment specifically on LDN use in eczema?
I usually use it topically in eczema as 1%. And that Zematop base I was talking about, and I just put it over the area of eczema. It's very effective for most patients.
Thank you. Dr. Smith, you referenced the 4R in your Fix for the Gut program. Can you reference what you're speaking about?
Yes, that's Module 4, which is on gastroenterology. And the 4R program is where you remove bad things. You want to go back and repair. You want to repopulate, and so there's an actual 4R program that you go through in treating people, which is like 6 hours of lecture. But that's Module 4.
Thank you. How long do we keep patients on LDN for IBD? Does the duration of treatment vary for different autoimmune conditions?
All my patients with autoimmune diseases, I have not stopped LDN. They've been on it for years.
Thank you. Thank you. I am receiving many requests to send the recording along with the slides. So I will be sending the recording out to everyone. Before I get to the last few questions, I just wanted to remind everyone that we will be hosting this course live in Las Vegas. We're going to be doing that May 4th through the 6th, and it will be at the Wynn. If you have questions or you'd like to register, please get in touch with me. My name is Lindsay. You can reach me at Lindsay, Lindsay, at a4m.com. You can also reach me at 561-777-6807, and you can also call your education advisors as well. Dr. Smith, how long do we keep patients on LDN? Is it maintenance for autoimmune or short term?
No, it's long term. It's long term, and I keep people. You know, again, it's been years on 4.5 milligrams. Now, obviously, if you're using it for weight loss, if the patient achieves weight loss and hopefully you've educated them on better eating practices and exercise, etc., then those people I do take off of LDN when they get to their desired weight.
Thank you. Dr. Smith, just to clarify, LDN is not a last resort option for anyone with autoimmune, but rather in conjunction with other treatments?
Yes, you can use it with biologic. You know, again, you guys all know me. I'm a very traditionally trained internist. I believe in traditional medicine. The fortunate thing about A4M and looking at an anti-aging approach is you have a bigger bag of tricks. So you never throw away the baby with the bathwater. In all honesty, most of my patients haven't needed a biologic, but can you use these in conjunction, meaning LDN with biologics? You can.
Thank you. Dr. Smith, can you reference where someone can purchase the books that we referenced in your introduction?
Yes, if you email me at faafm63@yahoo.com, then we can get you those at a wholesale price.
Perfect. And I will send that out to everyone on the call this evening, so you do have that available. Well, Dr. Smith, I'm receiving a lot of thank yous, a lot of great presentations. This is clearly a really important topic. Is there anything that you would like to say before we wrap up this evening?
Well, number one, I hope to see everybody in April at the World Congress for Modules 1, 5, and the World Congress itself in Hollywood, Florida. Number two, I really do hope everybody tonight decides to come and join us in person. You can take it online, but we'd love to see you in person at the Wynn. It's a beautiful property, and we have fabulous speakers. They're all sharing their own cases. Dr. Todd Lapine, Dr. Philomena Trindade, myself, Dr. Andy Heyman, Dr. Jim Laval. We're all going to be sharing our cases over the years of our most complex people. So you'll really be getting a lot of fabulous tips on what to do with these kind of patients on Monday morning.
Fantastic. I'll just leave my phone number again. It's 561-777-6807. If anyone has any questions, certainly let us know. We're more than happy to assist you, and we do look forward to seeing everyone in Las Vegas. It's going to be a phenomenal event. We will also have many of our exhibitors there to help fulfill your therapeutic toolbox, so you can go home on Monday and have all the tools that you need. There's also the faculty that Dr. Smith has referenced are so helpful. So if you have patient cases that you'd like to bring along, you're going to be working with a lot of like-minded physicians, allied health. So it's going to be a really fun weekend. We hope that you join us. And I thank you so much, Dr. Smith, for hosting this evening. It's always a pleasure.
Oh, thank you so much. And no matter what kind of healthcare provider you are, whether you're a physician, a pharmacist, a nurse clinician, you're a naturopath, you're a PA, this would be a great workshop for you all. Have a great night, everybody, and thank you so much, Lindsay, for facilitating the webinar.
My pleasure. Good night, everyone.